We'll go ahead and begin. Thank you for joining us for this virtual patient event sponsored by the Duke Cancer Institute. My name is Ted Alyea. I'm the Chief Medical Officer of the Duke Cancer Institute. And this afternoon, I'm joined by 5 experts so we can learn about COVID-19 and what it means for our cancer patients and the community. Next slide, please. First, I want to begin by a thank you. We are grateful to the community for supporting our team and for their role in making key changes to significantly slow the spread of infection. We're now resuming needed care for our community. As many of you are aware, in response to COVID-19 in our community, Duke Health had to delay some appointments, surgeries, and procedures. However, we're committed to resuming this time-sensitive care for patients. We understand that you may be anxious about seeking medical care right now because of possible COVID-19 exposure. But one of the greatest risks to our community during this time is delaying important healthcare maintenance and treatment. We want you to know that we have implemented several precautions to safeguard the health and well-being of our patients, visitors, and team members in our clinics and hospital. Your safety and that of our team is our top priority. We are committed to keeping you safe as well as our visitors and staff. We want to assure you that our processes follow CDC guidelines and recommendations, allowing us to provide quality care while keeping you, your family, and our team safe and healthy. I'll outline briefly just some of the interventions, including patient screening, visitor screening, and team members screened, masking of everyone in our facilities. Great attention is paid to physical distancing in our facilities, including our waiting rooms. As many of you may have experienced, we're now using telehealth on a routine basis. We continue to have visitor restrictions to limit the number of people in our facilities, and we'd ask you to note that prior to coming to your visit. Everyone is encouraged to use frequent hand hygiene. In addition, we're spacing out appointments to reduce the number of patients in the facility at any one time. And finally, in some groups, offering additional and extended hours at some locations. As mentioned, I'm joined by 5 experts from the Duke Cancer Institute to answer your questions. Chief of Medical Oncology at the Duke Cancer Institute, Dr. Peter Allen, who's the Chief Surgical Officer at the Duke Cancer Institute, John Kirkpatrick, the Clinical Director of the Radiation Therapy Program, Dr. Cheyenne Corbett, who's Head of Cancer Support and Survivorship at the Institute, and Becky Smith, who is an infectious disease expert from Duke Health. We'll now begin with some of the questions that have been previously submitted. We'll begin with our infectious disease expert, Dr. Smith. Dr. Smith, can you share with us the current status of COVID-19 in our community and what you see in the coming weeks and months?
Yes, and I just want to thank you for inviting me to this panel discussion. We've learned a lot over the last several months about coronavirus in our community here in Durham and in North Carolina. And we were just discussing how fortunate we were to really have a jump start on our preparedness efforts that really began back in January as we were closely monitoring this situation as it evolved in Wuhan. And because of that lead time, we had the ability to acquire the right personal protective equipment to keep our staff and our patients safe. And then it also gave us a lot of time to plan for that initial surge that we expected. We were very excited to see all of the mitigation measures put into place, things like the stay-at-home orders, the masking in public, and that really flattened the curve. And for those of you who haven't heard that term, when you have an epidemic, or in this case, a pandemic, the sort of case count kind of rapidly escalates as more and more people get infected. And then when you try to implement measures to slow that infection, you actually result in a much like lower and flatter curve. And that helps to allow for healthcare to take care of both COVID patients and patients with other conditions. So as we've implemented those strategies, we've actually seen that they're very effective. And as you just heard, they've been used to serve as a guideline for how we're going to safely reopen our clinics to patients. And so we strongly believe that these are working. We've seen them in action, and I think we've developed a way to continue to do them to keep everyone safe. I think the other take-home point is masking works. So for all of the patients and family members going out into public, make sure you're wearing your masks and make sure you're performing hand hygiene and not touching your face. Those are probably some of the key things that we've learned. Those things do work. Oh, you're on mute.
Another question would be, that's asked very commonly, is, are cancer patients at increased risk of COVID-19? And how should they assess their personal risk?
Yeah, and that's a harder question because we're still learning about this disease. But with any infectious disease, cancer patients are among some of those with a high risk for serious illness from all infections, because we know that their immune systems are often weakened by cancer or the treatment that they're getting for the cancer. I would divide folks into two categories. So if you had a remote history of cancer, but you're still in the surveillance phase, but not still receiving active treatment, your immune system is most likely functioning more normally, and perhaps you're at lower risk. Probably our highest risk patients are those with leukemia, hematologic malignancies, and then again, solid organ cancers getting active chemotherapy that might lower their white blood cells to a point where it's harder for their body to fight off infections. We have taken some measures on the inpatient side to hopefully evaluate whether patients might have asymptomatic coronavirus infection before we institute chemotherapy, again, for times where there may be an opportunity to wait a little bit. Obviously, chemotherapy is not an elective treatment in all cases, so in those times we've had to proceed. But again, we're still gathering those data. We certainly haven't seen a signal here at Duke that our cancer patients are disproportionately affected at this point, but it's still earlier in this pandemic.
Thank you very much. The next couple questions are directed for Dr. Allen. A number of people have asked, how have you and your teams approached surgery during this period of time? And is it safe to have surgery during this time?
Thanks. Yeah, those are frequent questions, and certainly the health system has responded with respect to our operative procedures. And as you mentioned earlier, many patients have had their operative procedures delayed until we felt that we had a better handle on the current pandemic. I would say, and actually I've been very impressed that Duke has instituted a number of policies, many of which that you noted in the beginning, to help protect both patients and providers who need to have their operations performed. And with patients who have newly diagnosed cancer, many times we're in a position where an operation really cannot be safely delayed. And because of that, we've decided to proceed with cancer operations, which we believe are not only necessary, but relatively urgent. And we've taken some additional steps in the operating room to protect patients. There are some concerns, at least from early data that are being gathered out of New York as well as out of Italy, that patients who undergo major operations who have COVID can have some significant challenges with recovering from that operation. And because of that, here at Duke, we instituted a policy where we are testing all of our patients who are going to the operating room for procedures to ensure that they don't have COVID-19 prior to the operation. And that's just an additional step that we instituted here, not only to protect our patients who are undergoing the procedures, but the other patients who are within the hospital and the providers who are caring for them.
Another question addressed one of the issues you raised, that at the height of what was felt to be the approaching crisis, there were patients who were delayed. It was felt clinically safe to do so. How are you and your team bringing those patients back? And is it possible that somebody could be delayed more than once as you all work through getting people back on their treatment plan?
Yeah, certainly that's possible. We're working hard to prevent that from happening, and we certainly recognize, particularly in patients with cancerous type conditions, the anxiety and stress around having an operation delayed for that type of a disease. From the very beginning, as soon as we started to postpone operations, we set up a system of criteria for how those patients would be monitored, identified, and for how long a period would that delay occur. And actually, there's starting to be some guidelines put out by the American College of Surgeons around how to approach patients, particularly patients with cancer diagnoses who need operations at this time. And actually, Duke was part of one of the few institutions to implement these strategies. And so we're tracking patients. We're remaining in touch with them about the timing at which their procedures will proceed. And we're using sort of a 5-tiered system of urgency as to when we will get them into the operating room.
That's very helpful. Lastly, with our visitor restrictions in place, how do you keep family and friends informed during the surgical procedure and hospital stay?
Yeah, that's a great point. And that's something that everyone should be aware of. And it is so unusual, I must say, as a surgeon, for me not to have a conversation with the family in the pre-op waiting area, in the post-op waiting area, and then seeing them on the floor in the patient's room. That to me is just so unusual. I must say that it's actually, to me, worked surprisingly well. And so I communicate by cell phone with the patient's family immediately after the operation has been completed. The nurses in the recovery room assist the patient in speaking with the family on the phone as soon as the patient's awake enough to do so. And then we're finding that, just like we're doing right here with video communication, that is becoming the new norm. And I just rounded on my patients in the hospital here about 15 minutes ago. And in several of the patients' rooms, I was on the phone on a FaceTime call with their families. And so everybody's adapting. And actually, in the end, although it has been a very unusual, I actually believe that this has worked relatively well, considering the conditions that we're operating under.
Well, thank you for highlighting that. I think we've all noticed in all of our disciplines using these video connections and telephone more frequently so that we can remain connected. Next, I'll ask Dr. Kirkpatrick to address a few questions that have been coming in while we've been on this call. Individuals are certainly concerned about potential exposures to COVID-19. Should they still get their screening for cancer done during this time?
I would say absolutely yes. I think in order to make an informed decision as a patient or a potential patient, and to appropriately schedule further workup and care, you need that information. You know, I think that, as you've heard already, I think we go to extraordinary lengths to prevent needless exposure of patients to anyone that potentially has COVID-19, and as we equally take care to prevent exposure of the providers here to the patients. So I think that when you come into Duke for screening, you could do so with a high degree of assurance that we're looking out for the patient and we're looking out for the staff being able to transmit anything to the patients. But I think clearly getting the information at the right time early on allows the practitioner and the patients to really make the decision on how best to go out and proceed.
Well, that's very helpful, and I think we'd certainly want to highlight that that the safe environment allows people to come back and get those. We'd also highlight that many of the screening procedures may be available in the Duke sites in the community as well. So work with your providers to be able to take advantage of those opportunities. A couple of questions.
I was going to just add that one of the things that we do is we have a lot of community affiliates, and we share information back and forth between the main campus and the affiliates. Hopefully they get some good ideas from them, and we get some very good ideas from them and their patients on how best to protect the patient coming in for screening or treatment.
Excellent. A number of people have actually written in while we've been on this call also asking if they begin their radiation therapy and it's interrupted by COVID-19 in some way, do they have to start at the beginning, or how do you handle that?
So we would handle that on an individual by individual basis. It would be really rare to get halfway through your treatment and then have to repeat the entire treatment. So generally we would make allowances for how much chemotherapy has been received, how much radiation therapy has been received, and make a very thoughtful decision about how we would modify that on an individual by individual basis. So they're getting appropriate treatment, and we're not causing, as Dr. Allen was saying, additional problems because of the treatment in the setting of a patient with, for example, active or recovering from COVID-19.
Similar to the question that Dr. Allen was asked about delaying therapy, presumably there may have been some patients who their therapy was delayed a little bit. How did you and your team approach that during this time?
One of the things that we did at the outset in radiation oncology was to sit down with all the different disease site providers and talk about what patients could delay their treatment without suffering any undue symptoms, who needed to be treated immediately. And essentially we set up a matrix that would cover essentially any patient that would cover us to treatment, talking about how we would do that, but recognizing that we had to address, again, this on an individual by individual basis. And we will also encourage our patients, if they have particular questions, the best way to resolve that, whether you're going through chemotherapy, radiation therapy, surgery, or some combination of the above, is to address those questions directly with your provider, because I think we've thought through this. We built on our experience. We reached out to our colleagues across the country in order to come up with the right algorithms for treating individuals based on their particular symptoms, status, disease, and frankly, how they were doing with the treatment.
Thank you. One last question, and I'll actually address these next questions to Dr. Corbett, if I could. During the COVID-19 crisis, many patients have expressed feelings of stress and anxiety during this time. What resources are available at Duke to help our community during this very challenging time?
Sure. Thanks, Ted. Our patients and their loved ones facing cancer experience distress surrounding their diagnosis and treatment and the associated impact on their lives. And as we face COVID-19, that certainly has created additional stress and uncertainties that they must face. At the Duke Cancer Institute, we have built comprehensive programs and services to meet the needs of them, our patients, and their loved ones. And these cancer support and survivorship services are available across all of our cancer center locations and provide personalized care to meet our patients' needs. I will say our patients, day in and day out, face a lot, and by and large, they're some of the strongest, most resilient people I have come to know. And so I think they have the experience and strength and resources internally to be able to face an experience like this. And in fact, we can also learn from them in terms of their life experiences and continue to use that to inform the care we provide and how we adapt through this particular situation.
In terms of
Sorry, I was going to say one thing regarding that. It's really important for patients and their loved ones to feel like they can communicate to the team. So tell your doctor, tell your nurse, if you have questions or concerns, it's really important that we know that. Your doctors, your nurses, and your broader cancer care team want to know that, and they need to know that in terms of how to best take care of you. And with that information, they will connect you to our team members. We have clinicians across multiple psychosocial fields who are here to help support you and your loved ones. So your care team can make those referrals, and you can also reach out directly to us, and we're happy to help point you in the right direction for services.
And I presume as well, your team has used a virtual platform for some of the support groups and events that were held formally in person?
Absolutely. So we've adapted to provide the majority of our clinical services via telehealth options, whether that's phone or video. And that includes all of our clinical services such as psychiatry, psychology, family therapy, child life, etc. We're also finalizing the launch of support groups to be offered in a virtual format, as well as other options for services that we typically offer on site, like our self-image services or prosthetics or orthotics. So we're in process of finalizing those. So stay tuned for that as well.
Thank you. I'll address the last couple of questions to Dr. Abbruzzese. Dr. Abbruzzese, can you comment on, we've talked a lot about patients coming back into the system. How about new patients? Jim may have a challenge connecting, so I'll just kind of address that issue. So new patient access is a priority here, and we want to help in any way that we can. We know there's some patients who may have deferred seeking advice and help for particular problems during the crisis, but we want everyone to be reassured that new patient access is a high priority and is not influenced by working through having other people return with their visits. And again, this is a high priority, and we encourage you, if you have issues, to seek attention. I'll also, a number of questions have come in the last couple minutes about chemotherapy. Similar to my colleagues in radiation therapy and surgery, each case is taken on an individual basis. As Dr. Smith had mentioned, some chemotherapy can be deferred, but in many cases, the risk-benefit profile is in terms of proceeding. So please address any of those questions with your providers. There are a wide array of chemotherapy agents, anywhere from hormonal treatments to immunotherapy. And each of these, as Dr. Smith said, have different implications in terms of immune suppression. But we would encourage you to continue with your current treatments plan that you have in place and address any concerns that you have with your provider. And finally, I'll just mention telehealth. Certainly, we've had a vast conversion to telehealth. It's been well received by many patients, and it's been well received by providers. And we're certainly interested in your feedback about this, and we do see this as a part of continued care into the future. We have just a couple minutes left. We'll go back to Dr. Smith and on an upbeat note, kind of tell us what you see coming in the future. And everyone's asking about vaccines. What's your current impression about where that stands, and who might be able to receive those when they are available?
Yeah, that's the million-dollar questions are, can I get an antibody test, and is it meaningful? And then when will we have a vaccine? Certainly the race for vaccine development is in progress. I think the question of will, quote, immune compromised people be able to get the vaccine is going to depend on whether or not it's like the live kind of vaccine versus the type, and the live type of vaccine is usually weakened, but there are certain patients who we don't give those to. Most people can still get those. And then versus a what we call an inactivated or sort of piece of the infection that your body makes antibodies to. I still think the vaccine is a long way away, and that we are all gonna, as we are currently doing, adapt to this new normal where we don't go around people if we have any symptoms. We are wearing masks in public. We are cleaning our hands frequently. We're learning how to not touch our face or rub our eyes with our hands. And we're learning how to stay, 6 feet away when possible. And if not possible, stay masked. So I feel optimistic that we've succeeded in flattening that curve so far. I think we're going to continue to need to do all these things. And probably one of the biggest success stories is the ramping up of the telemedicine for all of our patients who actually live very far away from Duke. There may be some COVID silver lining that now they can have some telemedicine visits with the Cancer Institute. So there's some hope here. And then, in terms of what's to be expected, I think we can expect to see some blips as there may be many outbreaks of infections if people relax the measures a little bit too much, and then we'll see more cases, and then everybody will realize, oh, we need to get back on track. So I think we're learning. This is the uncharted territory, but I feel so privileged to work at Duke and with such a great team. And I feel like we are in a great position to keep our patients and our staff safe and still continue to provide great care.
Well, thank you for those closing comments. And I'd like to thank the panelists who joined us today. And I'd like to thank you for joining us to learn about how we're keeping you, your family, and our staff safe as we have this new normal, as mentioned. I would finally say I would encourage you to reach out to your team should you have any questions or concerns. They're readily available to help with you. And again, thank you very much for participating for today, and thank you.